So now that we've talked about the elbow as a whole overall, let's talk more specifically about the humeral-ulnar joint. And specifically, let's start talking about how does this joint compare to the glenohumeral joint. There are a lot of similarities between these joints. Basically, you have pretty much a ball and socket joint, although at the humeral-ulnar joint we're going to consider this a hinge joint, but as you can tell, this portion here, just like the humerus is a ball, a round convex portion, that basically represents the trochlea, and then you could see here in the trochlear notch how much wider that is, how much more that encapsulates and encompasses the humerus as opposed to the glenoid, which is a very small fitting feature for that. For that reason, compared to the glenoid, which joint do you think would have more dislocations? And the answer would definitely be the glenohumeral joint as opposed to the humeral-ulnar joint. This is a joint that is designed to provide more stability, so that would be the answer here. So we're looking for stability from the shoulder joint. Even with the bony congruences here, you can see how this is meant to provide stability as opposed to the glenohumeral joint, which is meant more for mobility. And then another takeaway from this slide, even though we said this looks essentially like a ball and socket joint like the shoulder, it isn't. This is considered a hinge joint, and it has really 1 degree of freedom. But remember before I said it's approximately 1 degree of freedom, because even though we have flexion and extension with the ulna, there is a little bit of medial to lateral movement. It's hard to see here, but there is a little bit of medial lateral movement. With extension, you have a lateral deviation of the ulna, and with flexion, you have more of a medial deviation. We'll do a lab activity where this is going to make more sense. But for that reason, this is called a loose hinge joint, so not exactly a true hinge joint, because it does move partially into ab and adduction or valgus and varus moments. So we'll do more about this in a little bit. Alright, so in this slide you have 2 different pictures. You can see one here without load, so no load, and you can see the distal extremity is not fixed, so that would be your open kinematic chain. And then you have one with load, and so that would be your closed kinematic chain. Now let's zoom in on this and see what's different about these 2 different examples. You can see in the one without load, there's clearly this portion, okay, of the humeral-ulnar joint, where the trochlea and trochlear notch really do not completely articulate, so there's this free area within there. Whereas with the load portion, you can see pretty much the whole entire area is in, there we go, is in contact. So if you think about this, it's basically a semicircle, so it's about 180 degrees all the way around. And so with this example, you really are missing that middle third of that. And the degrees vary according to the source. I think the textbook says something like 30 to 120 degrees. But don't worry, there's just variability. But just understand the basic pattern is that when you don't have load, you don't have full transmitting of the force throughout. And the other thing that's interesting about this joint in particular is that, and if you could try this yourself, if you push against a wall or push against the floor, you notice that most of the pressure goes through your thumb side, your radial side. But then what happens, because of the interosseous membrane, the force gets transmitted from your radius to your ulna, and that's to evenly distribute the forces. And the trochlea is a good receiving force, good stable force surface where that can be absorbed here. So basically, to summarize this, with no load, you can see you just have it on the ends. With load, you have all contact. And why would that be important? Well, let's say you have a patient and they have some type of OA of the elbow, or maybe they have landed on their elbow forcefully and they have some loose bodies in there, or cartilage fragments that are in there. You definitely would want to avoid any closed kinematic chain exercises because that may be problematic and painful. So that's one example of this. Alright, so continuing humeral-ulnar joint, let's talk about the articulation a little bit further. How would you describe the joint surfaces? Well, you have a humerus here that would be convex, and an ulna here, which is going to be your concavity there. And so as the ulna moves on the humerus, you have a concave moving on a convex, so it's going to be a same direction roll and glide. With this humeral-ulnar joint, the most important aspect that we're going to focus on with our patients tends to be the one that is injured much more than other parts of the elbow, and that's going to be these three bundles right here. Let me clean a little bit of this up. Okay, there we go. So these three bundles are known, remember they're on the medial side, so they're known as the medial collateral ligament, or MCL, and also they may be referred to as the UCL because they're on the ulnar side, the ulnar collateral ligament. One thing to mention is that of these three bundles, there's one particular bundle that tends to be the strongest. And I'll give you a clue for what that is by, I got a little sound clip that I prepped for this. So let me see if I can play this. Okay, so if you remember that, that is the AOL. You've got mail. And so the AOL is also another name for the anterior oblique ligament. And that is definitely the strongest part of the MCL. And it's going to be the primary restraint for the forces that the MCL is going to resist. And we'll talk about that on the next slide. And here we are. So zooming in a little bit on this, you could see that with the ulna here, if the ulna is being pulled in this direction, the MCL would prevent that. So it's going to prevent a distraction or a traction force of the arm. And we'll talk about when that may happen. Another time it's going to be protecting is if you get a compressive force here, that's going to cause a tensile force here. So that's going to make the humerus go that way and the ulna go that way, essentially, and that would be problematic for the MCL. And so that is going to be called a valgus force, which is essentially a force from the lateral side going in a medial direction. And so here's the picture of your valgus force. And whether we're dealing with the knee or the elbow, a valgus force is going to cause a potential tear to the medial collateral ligament. At the elbow, a valgus force to the knee is going to cause potential damage to the medial collateral ligament at the knee. So in this slide, we look a little bit more in depth about the compression forces that are transmitted through the hands. Even though our hands are generally non-weight bearing, there are many times that we transmit forces, whether we're doing a push-up, whether we're riding a bicycle, whether we are pushing or moving an object. You could tell from the picture here that if the compression is going in this direction, the radius, which is the more distal of the bones, is generally going to absorb most of the force. A smaller arrow here for the ulna, but you could see here, the interesting thing is, once the force goes up the radius, it transmits through the interosseous membrane to the ulna, and to the ulna and radius, the force is relatively evenly distributed so that it goes up further to the humerus throughout. And then the question here is, are there other ways to transmit forces differently through the forearm? And if you think about some of the modifications we make, whether you're thinking about a patient and how they may have a crutch or a cane, you know, there's some altered grips they have for these devices to shift the weight slightly to the ulna as opposed to the radius. All right, so let's pick up the discussion talking about the MCL or UCL. It's used interchangeably a lot of the times. What are the two main forces at the elbow with a traditional throwing motion, overhead throwing motion for baseball? So let's zoom in on this a little bit. And so you can see the lateral view of the throwing motion. And if you look at this, you'll see the ball is definitely going to create this distraction force on the arm, on the radius and the ulna, both directions. But if you see the angulation here, you can see how this creates that valgus moment force with that. And potentially this would be the cocking phase of the baseball throw. As you're bringing that arm back, you're cocking it back. Then after that, you start the acceleration phase, which is rapid. So you're changing directions from one extreme to the other very rapidly, and so that's going to create a large acceleration. The mass is going to be relatively minimal, but with that large acceleration, you're going to create a significant force right there at the medial epicondyle, and especially at the AOL or portion of the MCL/UCL ligament. And so how is this different with a sidearm throw? So you can see the sidearm throw pictured here more so. So you're still going to have the same distraction force there, but you can see there's a greater angle that's distributed there. And so what this does is it ultimately creates this longer moment arm at which you're distributing the force. Now, even though this is an image looking from the anterior direction, if you were to look at it from other positions or more in a three-dimensional view, you'd see there's more torque basically caused by that position. And so for this reason, it's usually discouraged to throw sidearm or throw curveballs until individuals get older, usually between the ages of 14 to 16 years old. Sometimes not at all, because this definitely causes more strain and trauma to the UCL structure. So let's talk about another condition associated at the medial elbow, and that is little league elbow. This can be very common among adolescents, and you can see, I'll zoom in here a little bit over the medial aspect. Now you could see where the MCL would be, which isn't exactly injured. However, the force that the MCL is exhibiting on the medial epicondyle can pull, basically create this force vector in this direction, and that repetitive motion can pull on the weak spot, which is the growth plate, or sometimes known as the epiphyseal plate. And that continued force, repetitive, in that developing growth plate can cause trauma to that area. Initially, that could just be a stress reaction, or it could be a full-out fracture of that growth plate. And of course, if that is injured prior to the growth plate or epiphyseal plate closing, there could be a length difference with the humerus on one side versus the contralateral side, and that would be a significant issue. And then the question here, which styles of pitches should children avoid till 4 to 16? I said that one on the last slide. Sliders, curveballs, sidearm throws. Generally, the overall fastball is recommended to master that before you work on any of the more stressful positions. And even with professional pitchers, they may try and limit the amount of curveballs due to the trauma to the medial aspect of the elbow. And so then the last slide in this little lecture is going to be dealing with the UCL and MCL a little bit, and a little bit of the surgical techniques for that. So reconstruction of the UCL has been nicknamed, what is the question? That is the Tommy John surgery. So this is Tommy John pictured there, who was the first person to really receive this surgery back in 1974. And so I looked this up. He had an 18-month rehab process, which is significantly longer than it is now. But he was able to continue pitching after that. He actually won 164 games as a pitcher after this in the major leagues, and he retired at the age of 46. So he did extremely well after this surgery. And fun fact that I read is that Mark McGuire's dad is a dentist, actually, and he was Tommy John's dentist when he was growing up, so I thought that was funny. Javelin throwers, you could also see this is significantly more mass than a baseball would be, and you could look at the position of his elbow there. Even though with this they might not perform as many repetitions as a baseball pitcher, they may not be throwing the javelin something like 200 pitches or something like that, because a baseball pitcher, even though in a game they may only throw 70, 80, 90, 100 pitches, they're still warming up, they're still doing additional pitches after that. But javelin would still produce a similar amount of force, it's just less acceleration but more mass, so it equals out still a significant amount of trauma for that. So that's the main information on UCL and MCL. Okay, then before I go, I did want to leave you with one last thing. We forgot to do cheesy joke on the last video, so I went through a few bad ones, but I got this one. Did you hear about the restaurant on the moon? Great food, no atmosphere. Okay, there you go. See you next time.